So the ACR and the EULAR guidelines are similar in many respects. There are a couple of differentiators. One of the unique differentiators in the EULAR guidelines that were recently updated in the end of 2016 was the addressment of ways to prevent RA, or ways to assist in helping with the symptomatology of UA, and that would be addressing obesity and smoking. The other thing that is similar between the two is going to be the treat to target. So this is addressing the patient's comorbid conditions as well as the expected side effects of the medication, and working between the rheumatologist and the patient to determine what that targeted outcome is, and then agreement to treat to that target, hoping to get patients through that initial therapy, looking for 3 to 6 weeks before most patients see a response, and then up to about 3 months before we start seeing some of those broader effects, and then treatment a full 6 months before we begin to look for additional agents. As far as which guidelines should be followed, what we see more often in the United States is the ACR. Most folks are more familiar with those guidelines. However, if you look at the two together, the determinations on how do we diagnose the disease, that's a collaboration between ACR and EULAR. When we look at the guidelines themselves, both start with methotrexate as the cornerstone of therapy, and then seeing that methotrexate through, that first 3 months of therapy before there's dose escalation. And many times for early arthritis, the dose escalation could be adding on a second or a third DMARD, and then maybe treating the flares with glucocorticoids.